So we're very excited to have Melissa Fries talk today on one of our favorite organs. That's mysterious, and if you aren't intrigued, the title certainly was fabulous, The Rise and Fall, Full Life in 266 Days. But thank you so much, Melissa, for coming. I had the chance to look at some of it, and I know we're going to really have you come back and talk some more later on, but really appreciate you coming.
Good morning. My name is Melissa Fries. I'm the Director of Genetics and Fetal Medicine at Washington Hospital Center. And we're going to talk today about the placenta. It is very difficult to talk in 30 minutes about an organ that has journals dedicated to it. So you can understand that this is going to be a little bit on the more superficial side. But I termed it the rise and fall of the placenta because the placenta is truly the shortest-lived organ in our body. We think of pregnancy as being considered 280 days, of which 14 of those are before you're pregnant. Then we can call the placenta from the time in which we actually have conception to delivery. So it's about 266 days. I have to learn to do this a little bit more.
Up and down arrows is on the
okay. There we go. These are the objectives. I want you to know a little bit about the basic structure and function of the human placenta, some of the genetic factors that influence the development and its function, and then understand some developmental changes in placental function that can then impact fetal outcome. And we will have a demonstration of that as we go along. As I said, the human placenta is the shortest-lived organ in the body. We term it, because placental mammals are very well studied, it is important to understand that there are some features about it that we share. They are called hemochorial, meaning that the maternal blood comes in direct contact with the trophoblast tissue. And it is chorioallantoic, meaning that the tissue between the two blood systems arrives from specific aspects of the mesoderm of the fetus, which is a chorionic trophoblast and the allantoic mesoderm. It's a chimeric structure. It contains both maternal and fetal structures, so it is one of our most unique features in the body. Here you can see the time course from fertilization to implantation. You can see ovulation occurring at about, you can see the implantation of the fetus or the embryo is going to occur well after our actual fertilization process. And you can see that by the time of implantation, there is already dedicated tissue that is going to become the placenta. This is the view of it. By day 4 to 5, there's a clear separation of what will be the embryo, that inner cell mass right there, and then the surrounding trophoblast, which is the outer cell mass. We don't have a sense on how this partitioning occurs and what are the trophic systems that demonstrate which group of cells will become embryo, which will become trophoblast. But at this particular point, they're all pretty much pluripotent, especially those obviously in the embryo, but still somewhat in the trophoblastic area. You can see in a more constructed area the inner cell mass and the outer cell mass of cells, which are roughly sort of cuboidal and are going to be then variable in what they will form. At about day 7, which would be menstrual day 21, the blastocyst, that structure we saw before, implants. And you can see this desert anatomy right here of the endometrium, which is where the blastocyst is implanting and then will burrow down into that welcoming velvety tissue that will then continue to support it. If we look here from day 21 through 27 to 44 days, you can see then the initial superficial setting up on the endometrium then burrows deep into the endometrium and then protrudes outward. And you can see the development of the placenta initially from this early enveloped blood vessels to a structure that then starts to have, and do I have a pointer? Yes. To a structure that starts to develop these columns of tissues, columns of trophoblastic tissue that are then moving invasively like military columns advancing on a battlefield into the endometrium, with a development that will end up so that the maternal blood vessels are substantially altered. These tissues have trophic systems within them that then cause the change of the maternal blood vessels dramatically, so that the maternal blood vessels will enlarge and then will envelop the villus structures here, enabling them to be in contact with the villus structures so that the maternal tissues and blood system can then carry the nutrients needed. The initial growth is very rapid. The trophoblast is proliferating way, way, way more than the embryonic cells, which makes sense because obviously at this time we've got to nourish it and support it. But at term this shifts. At term there is a 40-fold increase in the size of the placenta relative to the size of the fetus relative to the size of the placenta. And so you can see that there must be an amazing infolding of the placenta in order to justify the growth of the fetus, because it has to then be much more superficial in surface area in order to develop this. This is the appearance of the mature placenta at term. If we're looking at the mature placenta here, this is the cord insertion. This one is a little bit eccentric. Here you can see this glossy blue surface. These are the umbilical arteries, which are coming out of the fetus, going into the placental structures here. And this is the umbilical vein coming under the arteries, coming through here into the cord, which will carry the higher oxygenated blood into the fetus. The overall appearance of this is the fetal surface, glossy and covered with the very fine chorionic membranes and multiple thin webs of vessels that come through. An extremely vascular structure, and you can see also in here there are also some areas that appear whiter than others. These are areas where there's probably either deposition of superficial fetal squamous cells, or maybe areas in which there has been minor areas of infarct. The placenta has multiple functions. It serves, first of all, to anchor the embryo to the uterine wall. There are some mammals, such as the armadillo, where the embryo does not anchor to the uterine wall for a long time. It actually is vital that it not anchor, because the armadillo has identical quadruplets, and if it were to anchor, it would not divide into those quadruplets. Therefore, the anchoring, we believe, not only fixes the embryo, but may have an impact in terms of its actual subsequent division and function. It has also the function to prevent rejection by the maternal immune system. If you can imagine, you're looking at a fetus that does not share 100% of the maternal genome, and therefore our usual response is to reject this. So the placenta has to run block for this and remain the interface between this. Naturally, we talk about the transfer of nutrients, gases, waste products between mother and fetus. These are obviously the vital thing that we view the placenta for. It has an endocrine productivity, human chorionic gonadotropin, placental somatomammotropin, which are vital in terms of making maternal hormones both insulin resistant, so that there is an increase in the amount of glucose, and really then in terms of supporting the placental function overall. And then by 40 to 42 weeks, it's done. It dies. And so its life is over at that particular point. The genetic basis of these placental actions is still very much in study. Clearly, the adhesion and the invasion process requires a lot of variation on surface cell integrins that are on the actual blastocyst itself. One of the key ones there is something called L-selectin, which is an adhesion molecule that we see on the surface of a hatched blastocyst, which then enables it to attach to other glycoproteins on the maternal endometrial side. It is modulated by chemokines and cytokines. Anytime you see this word kine, it implies a kinetic or a moving structure. Remember, these are the things in our bodies that are going to be then brought to an area, usually by inflammation. So you can imagine this is something that is being modulated by these inflammatory modulators. It may impact how that inflammation reduces the actual immune sensation of the difference in the placenta. And it also implies that by the fact that we're looking at chemokines and cytokines, that there is an inflammatory nature to what the placenta integrally does, indicating that it may be more sensitive to changes in this. There are also HLA class I antigens that signal natural killer cell activity that may impact the modulation of the immune system in this regard. And all of these are part of the initial invasion and genetic process that influence the placenta in itself. It is a remarkably unique system for its capacity to adapt. It is a sensor of both maternal and fetal environment, so that there is the capacity to adapt to optimize nutrient and gas transports, so that there can be both sparing of fetal brain function in times of either deprivation or altered function, and to allow fetal survival. So extraordinarily unique sensing system for which the details of it remain to be worked out by those who specialize in this area. The transfer of nutrients can be varied, but if you think about it, the paradigm is the smaller and more polarized the molecule is, the easier it is to enter the placental system. And it can be either by diffusion, either simple or facilitated. For example, glucose. The fetal glucose is almost always lower than maternal glucose. Fetal glucose is regulated by the fetus's insulin-based system. And even in a diabetic mother, the fetus is not diabetic, therefore it has an intact insulin developmental system. But the fact that the fetal glucose is typically lower drives the maternal diffusion gradient into the fetus and therefore promotes that the fetus will then receive more glucose. There is also a facilitated transport for specific amino acids, which are either some of the ones that are polarized or non-polarized. And then there can also be an endocytosis process for fats and fatty acid processes that then enable it to cross the membrane. We think about also, in part of this, is that the placenta is in fact metabolizing many of these as well. And whenever we think of teratogenic structures, we believe that it is maternal metabolism of a teratogen, fetal metabolism of a teratogen, but also the placental metabolism of the teratogen that in fact enables it to both reach or not reach the fetus and therefore impact what it's going to do. The critical placental process, I think, that I've found from all of the review is the differentiation of this pluripotent cytotrophoblast, which is what is early development, into both syncytial trophoblast, which is the multinucleate cell layer and is responsible for the hormonal production of the placenta, and then the extravillous trophoblast, which will then continue as a cytotrophoblast, and is this invading army of tissue. This invading army migrates into the uterine spiral arterioles and replaces the maternal endothelium and invades the smooth muscle. And it converts those high resistant vessels into large diameter, lower resistant vessels. That is the key piece for how fetal growth will persist. There has to be an increase in placental transport, both by this branching and non-branching development of blood vessels termed angiogenesis, and by this differentiation into the different types. These functions are then going to be varied. They're either varied by transcription, which in genetics means how we trigger new genetic turn-on. They're either varied by epigenetic phenomena. Remember that the maternal genes in a placenta are more likely to be imprinted and dysfunctional with enhanced paternally expressed genes, and that there may be physiologic and environmental factors that impact this as well. So this is a photo from a text in which you can see in the normal placentation and abnormal placentation, you can see that here we have the invading cytotrophoblast marching through the maternal vessel, replacing the smooth muscle here, and leading to this very large diameter, smooth intervillous space that is kind of flaccid and balloon-like and is not going to be responsible to pressure changes because it's so limp. However, if there is a failure of that, you can see that then this smooth muscle persists or may continue, the intervillous space then remains muscular and responsive then to whatever controls smooth muscle tension, and then restricts the blood flow. So how would we put this together? You can think that there may be initially this abnormal poor placentation, and then combined with that, there is altered blood flow leading to an oxidative stress that can then subsequently damage the placenta further. And then from that combined poor placentation and oxidative stress, you end up with this final fetal growth restriction, which can also be the hallmark for preeclampsia as well, and the subsequent complications that we know from this. The critical aspect of fetal nourishment, then, has to do with the development of appropriate angiogenesis. This is a structure of angiogenic factors. There is a balance of pro-angiogenic factors and anti-angiogenic factors. And the study of these is an enormous process at this particular time, because we are viewing that there is the potential that we may actually understand a little bit of this that would enable us to pick up or predict who may be at risk for subsequent downstream problems. The pro-angiogenic factors, typically VEGF, which can be induced by another structure called hypoxia-inducible factor. This basis structure, which is a receptor, will bind this tissue here and bind it using this combination of something called FLT1 or FLT1. It will then also bind placental growth factor, which is activated by oxygen content and will bind to FLT1 as well. Interestingly, FLT1, if not bound to cell surfaces, is called soluble FLT1 or S-FLT. And soluble FLT1 is anti-angiogenic. And we'll talk about, I have a cartoon that may discuss that a little bit more clearly. If you see right here, here is vascular endothelial growth factor A. And this is its receptor and where it binds. It's a single signal transduction molecule of the receptor. The product here binds to the receptor. There is then a transmembrane process, a cyclic AMP, tyrosine kinase process that then probably ends up with phosphorylation and then subsequent transduction of a gene product. This binding then is really critical to the development of angiogenesis. You can see, though, that this also placental growth factor will also bind to this product and bind right here. If this right here, this structure, which is called also FLT, has an excessive production, there is no longer space for it on the cell surfaces, and therefore it is soluble at this particular point. And the excess production of this will bind VEGF, but because it's in the soluble process and not binding, it inhibits the signal transduction for angiogenesis and therefore acts in an anti-angiogenic process, therefore preventing appropriate. Now, why this should be upregulated is not clear, and how it is that this upregulation and inhibition of where it's going to bind here occurs is still unknown. But we're looking at ability to identify the amount of placental growth factor and the amount of soluble S-FLT to identify people who may be, in fact, having abnormal angiogenesis of their placenta, such as in preeclampsia. And these may be markers that we can look at. Histologically, this is all paralleled by the development of the villus. The villus, which is the primary structure of the placenta, is a amazingly undifferentiated thing. It doesn't have to become a retina. It doesn't have to become a BET cell. It doesn't have to become something else unique, some kind of gamete or whatever. It's just this structure of vascular tissue. And it initially is a large, sort of bulky structure that is poorly vascularized. It's got these two layers of your trophoblastic element, the cytotrophoblast and the syncytial trophoblast. But as it matures, you can see, let's go back here. Look, this is the big sort of bulky ones. Remember, surface area for this is actually going to be less because it's bigger and bulkier. And as the placenta grows, those villi actually become smaller, more velvety, more surface area, because they're no longer big and bulky. They've branched and divided and formed new blood vessels. So that there's a branching and the proliferation of this vascular structure. They're smaller, but they have greater surface area. And ultimately, you'll end up with 5 to 8 capillary tufts of the fetal blood system adjacent to the maternal blood system that will enable that then to get a passage of tissues and oxygen. So this is the final general schematic, if you can see, of the placental villi. We start here from maternal blood vessels here in the uterine wall. Then you can see these large, loose, floppy spaces that are filled with maternal blood. And here we see the fetal tufts of the capillaries separated by their endothelium only that enables then the passage of those nutrients and oxygen into the fetal system here into the fetus.
Can I ask a quick question, because that's such a good diagram? So when you have a sick placenta, is it more the vascularity on the maternal side or the?
Yeah, and Dr. Jelen goes, because it's a great question. We believe that it may be a combination of the both, but probably it's because maternal blood vessels, or at least what we understand now, fail to develop into these large spaces and therefore fail in their capacity to provide support for the fetal structures here. But it's you can imagine, if there's less oxygen there, then there's going to be oxidative damage, as I said, to the placenta, and that will then impact the fetal side of this. So it's a dynamic feedback in this process. Finally, when we look at the term-appearing placenta, you can see here many small villus tufts filled with fetal blood cells right here. And in maturity, you'll start to see some decline. None of us get more healthy as we age, the placenta the same. And here you can see this pinkish stuff that reflects areas where there has been focal necrosis. And this final schematic can show us the little surface tufts right here. Here's the mother's blood, the surface tufts of the endothelium right here. Here is the syncytia trophoblast right here, the cytotrophoblast, and then here we are with the fetal capillaries, just simply percolating across to this process here. The theme of the placental pathology is that there is accelerated maturation of the villi. If you can imagine something whose job is to be done in 266 days, that villi have to grow, develop, and then mature. So there is the pathologic discussion of what we call accelerated maturation. The villi appear more mature than expected for gestational age, and it's often associated with a villus infarction. In pathology, you can imagine everything that is blue is going to be nucleated, but then all of this pink stuff reflects less nucleated tissue. This is areas where you can see no fetal blood cells. This villus is completely infarcted and appears like the villus of an aged placenta. It's often termed villus ischemic change, and we can, in fact, see it with ultrasound. Here we can see a beautiful view of a very nice, healthy placenta at approximately 18 weeks of gestation. It has this sort of grainy heterogeneity to it, but it's somewhat not the same hypoechogenicity here of this. It doesn't have hyperechogenicity. It's just sort of a diffuse grayness that reflects a more uniform reflection of the sonographic signal. As opposed to this, which is a 38-week placenta, and here you can see these whitish things throughout here, which reflects areas of calcification. Then calcification is often a placental consequence of infarction or of some kind of necrosis. So we can clearly see that in this particular view.
So if accelerated maturation are supposed to be areas of infarction, how come it's never described like what percentage of placental volume we see accelerated maturation?
I believe because that would imply that they had to look at the entire placenta. Very often you can get an overall impression of it, and I'll show you that with an example that I have. But you typically will take, most placental pathologists have this structure as big as a dinner plate, and they're not going to cut it into very fine, minute segments. So they're looking at proportion of what they see there, but some of that may be underestimation. You were going to make a comment, I think, Anna. No?
Just for placental abruption, it's much easier to get that estimate. Well, no,
Actually, abruption, no, because you can't technically see.
Because very often it'll peel away.
Infarction, you can't.
Ultrasound is hard, but on pathology.
No, you can't see abruption of pathology. Grossly, because usually it's just like a retroperitoneal, retroplacental hematoma. You don't have
That's a good
This is, I think, this is the view, I think, for you, Tay, that you can see this placenta is grossly infarcted. And here, even the least pathologic of us can pick up that all of this white stuff doesn't look like that healthy pink tissue that we had before. And this is the area of the infarction that we would see in this regard. And the fact that the baby was able to potentially survive with this is, I think, a credit to the sort of ability of a few villus tissue to pass oxygen, and the fact that we have very sharp knives. Okay. So I'm going to give you just a little bit of a story of ultrasound imaging of placental progression so you can actually see an example of it. So this is a 31-year-old healthy mother with spontaneous dichorionic diamniotic twin pregnancy, baby A, male with an anterior placenta with normal growth, and baby B, female, who had an anterior, and I term it fused placenta because the placenta was adjacent to the placenta of the other fetus, and that there was a drop-off in growth seen at 20 weeks. And here you can see this right here. This is the placenta of twin A, who at this point was at 88th percentile and well endowed. And here you can see twin B, and you can get a sense already that this is a whiter looking placenta than that. And this is their area where they abut. Twin B at this point was at 26th percentile. However, as we move on just a few weeks later, you can also see that twin A right here, continuing along its healthy track of that nice sort of homogeneous look, and twin B
better than a land design.
Increasingly white, and areas where there's these whitish areas where it would imply that we're just no longer getting that good vascular supply.
You can see the line.
At 25 weeks, we could see baby had dropped to the fourth percentile. Here's the placenta here. Here's B chugging along. The twin A right here. The healthy baby with a nice normal blood flow to the brain at 67th percentile. And then by 28 weeks, baby B, our sick baby, started to show significant cephalization of flow to the brain. Here you can see the PI had gone to 1.23. And baby B's umbilical blood flow had reflected that we no longer had a flexible system with capacitance in the blood vessel. We were losing blood flow during diastole. So this is absent end diastolic flow that we're looking at right here. And by 29 and 5, we not only were losing it, it was reversed. And at this particular point, we elected to deliver. So we delivered by cesarean, and baby A was 1,587 grams and was intubated until day of life 4, and baby B was almost half that weight, but was extubated at 8 hours, which is a reflection of how sometimes oxidative stress has a maturing effect. And this is the appearance of the placenta, and I apologize if it is a little blurry. So this is twin A, the healthier, larger baby. And the placenta here, you can see, was at least a third size larger than the placenta of baby B, the sicker baby here. You can see right here. You can also see this is clearly dichorionic. You can see it split there, and also you can almost get a sense of some of the intervening type of decidual cells that imply that this is di-di.
Great picture, Melissa.
And then here you can see on the fetal side, this is A. This is the beefy red structure of A, well vascularized, and this is B. And see how pale and white and infarcted all of this is. So this, I think, is a comment to Tay in that we can sometimes see grossly some of these areas. And also a comment, I think, for Anna is that if this were an abruption, we would see probably residual tissues of the blood and clot right there on the surface right here. But this placenta, for some reason, had this accelerated villus maturation. So this demonstrates how we can follow with ultrasound some of the features that we can see. I think there are many continuing questions that half an hour is only an introductory time. I would like to know myself, how do we have the capacity to identify variation in blood supply and modify fetal blood flow? How does it adapt to that? How can we analyze maternal serum products to predict poor outcome? And what would be some of the benefits of this? How can we intervene? And what would be potential non-pregnancy use of the placenta? We have 2 sickle patients who are collecting placental stem cells potentially for their own haplotype bone marrow transplant. Could be a very exciting option. We can explore these and other questions with future lectures with people who may be specialized in these particular areas of understanding. So I'll stop here. Any questions?
I think that case is fascinating because she also had an IUFD, so it's kind of impressive. Actually, before this pregnancy of twins, she'd had a prior IUFD. And so basically the question is, why did one of the placentas actually do well? Like, obviously her uterus isn't very healthy, or something's going on that the vasculature and implantation is not working very well in 2 out of 3 of the cases.
Right.
Why in the 3rd case
did
it work?
Did it work? And you know, how could we continue to follow that? The question for obstetrics, I think, for anyone is gestational age. Anytime you have a question is, how far can we get this baby? How long can we let this baby whimper along on 2 cells of oxygen? It's a tough call.
It's so hard.
You're balancing maturity versus fetal well-being, and it's a tough call to set up.
Do you always wait for the reversal in diastolic flow before delivery?
It's a great question. We had actually followed her absent end diastolic flow for, I think, close to 4 weeks. It had been initially intermittent, and we did find that if we hydrated her very vigorously, we were able to actually impact that and reduce some of the absent end diastolic flow so that we did have some increased flow if we hydrated her super vigorously. But then over a period of time, it no longer, I think of it, you know, if you imagine the placenta, instead of being a sponge, for her, it was like a brick. And if you give an increased fluid hydrodynamic force, you're going to force something through the brick. And so that at least got it there. But we watched it, and then throughout the entire cord, it was reversed.
We don't always watch the song. It was partially because she had twins.
Yeah.
So we were, like, trying to balance the fact that we wanted the one that was doing well to do well.
Because we sacrificed that one.
It
for
started
the
at, like, 25 weeks, and at that point we were like, if we deliver them both now, they'll both die potentially. So it's a very difficult balance.
But still, it's interesting. So you're blaming the maternal uterus, and I'm thinking that so you don't think it's the fetal placenta?
No, I do. I think it's the problem with the placenta is because of the uterus, though.
Yeah, maybe the maternal uterus has such hyper-rigid vascular structures that even with appropriate angiogenesis, it may not adapt it adequately. Or it may be that there is scarring of the uterus, that when it implants,
Right.
it's not going to be in a well-vascularized part of the uterus.
The area
Instead
uterus
of being
which
that
is
richly velvety endometrium, it's a thin sheet of not such good blood vessels.
Right.
All of this is
The thing is, I
speculative.
really wanted to look at this because there's a lot of placental stuff, but there's really no myometrial data. There's like a couple of studies. So all you would have to do is take a few myometrial biopsies at the time of C-section, look at those as far as vascular damage, and think of it as an end organ. Like if you think of the uterus as an end organ, it's probably going to have damage in patients with diabetes, hypertension, things like that, which is what we find. And so, I mean, my whole idea was to find somebody who's a vascular pathologist to look really closely at the vasculature of the uterus in these biopsies. It really hasn't been looked at very closely in the literature.
So there was one statement on one of your slides where it made me wonder, where you mentioned sort of like the shape of the vascular spaces that could affect, how it functions. Did anyone try to look at like the three-dimensional modeling of villus spaces to see how it looks different in one patient versus another? Because most things in biology, the anatomy goes with function.
Absolutely. To the best of my knowledge, no. That's a fascinating idea. I mean, I think the other feature that you'd have to look at is it's not only the shape, but surface area.
Yeah.
So if you had,
It's a great thing with all the MR imaging.
Yeah, I mean, people have looked on the placental side, but what you really want to know is the myometrial side as well. You need that.
because that's where the maternal blood vessels are.
And unless you're doing a hysterectomy.
Well, no, because with all the MRIs now being
Yeah,
done of
but,
placenta,
yeah.
you could do, volumetric studies of that intervillus space. It's just.
But I was just thinking of shape. I mean, if you really wanted to get shape.
Well, you could do everything. If you're going to do 3D reconstructions, you could get volume, you can get shape, you can get surface area. There's lots of different, mathematical features that you can take of this once you have.
But sorry, surface area of the
Intervillus space.
Can you
You're looking at
that you. Have you seen our images?
Well, just to me, the way I think of it is a simple structure versus a complex structure. Most things in biology are nonlinear. It's chaotic, and you think of mountains.
Life too.
and trees and leaves on trees. It's that whole kind of chaotic space that allows it to be so multidimensional that makes biology. And I wonder if it looks messy, and that's why general surgical pathologists don't like to look at the placenta. It sort of makes me wonder
But the
if you
surface
could measure the
is smooth.
multidimensionality of the shape of the intervillus space.
But where are you, because the surface itself is smooth, so you're saying looking at the internal.
Well,
but the
while it's
surface,
implanted, because what is
it's actually
implanted is
much-
not that,
It's probably actually much more interesting.
right.
It's just that we can't see that when we're
Right.
looking at
Very hard to
placenta
take
after
it,
delivery.
after
where,
delivery instead of
the intervillus space
yeah.
is collapsed.
How would you do that, Kay? How would you model
I
that?
don't know. I'm just
Yeah.
it just sparked the thought in my head.
Yeah,
And
I mean,
and I tend to look at things sometimes mathematically, and it just made me wonder.
Yeah.
Because I think that was really that doing a nonlinear dynamic analysis of
Or even just looking at the
surface
sometimes
volume
the
of the
villi.
intervillus space might be really fascinating.
Like when you were looking, like she talks about, which I haven't thought about in a really long time, the way that as they mature, they actually have more branches. Like if there's a way to quantify those branches
Because if you
somehow.
talk about lung development
Yeah.
and the alveoli, it's just the branching is the same thing. I'm starting to envision the intervillus space looking something like that, rather than a simple square or cube.
Kind of like a root system almost,
Yeah.
looking at it in terms of how it is in.
Right. Yeah.
So there we were talking about how to kind of look at the vascularity of the placenta, either with ASL or time of flight. But the
Good luck. We had a meeting last week, and I don't know how you do this, because the arteries, you don't know which way they're coming from, because you don't even know the baseline anatomy. And then once they get in the fetus, once they get the uterus, then they branch out all over the place. So, to do ASL, good luck.
What is ASL?
It's like with MRI, we can look at perfusion by applying tags to vessels that bring fresh blood to an organ.
Oh.
But the problem is that in placentas, we don't know where the uterine arteries are.
The
They come
intervillus
in.
space, I think would be really
So,
fascinating.
I mean, they're usually just
Oh, I'm sure.
4 major entry points.
Right, but it's finding them.
Because people are great at
But I still think if you win,
very good